Good day. You're welcome to this lecture module. The topic is male and female surgical sterilization. And a bit of introduction before we proceed. My name is Dr. Adeyemi Adefison from the State University College of Medicine, Ado-Ekiti, Nigeria. I'm a fellow of the Medical College of Obstetrician and Gynecology of Nigeria, as well as fellow of West African College of Surgeons. So we shall proceed now. Objectives of this module is to be able to have a grasp of what surgical sterilization is, the timing of female surgical sterilization, and then you should be able to learn methods of female surgical sterilization as well as male surgical sterilization. Then complications that could arise from both male and female surgical sterilization, and also efficacy of male and female surgical sterilization. As a way of introduction, I believe in the course of these lecture modules, family planning and contraception has been taken care of. And so surgical sterilization is a form of modern contraception, and it's also a permanent form of contraception. Worldwide, about 222 million women or reproductive age group depend on sterilization to prevent unintended pregnancy. Out of these, about 180 women use female surgical sterilization, while their partner, about 42 million of them, use male surgical sterilization. It is estimated that about 30 to 50% of couples depend on sterilization for contraception. And in fact, surgical sterilization is the most commonly utilized method of contraception in the US. About 700,000 females get sterilized annually. Reversal of sterilization is possible, but has a failure rate, which is very high. Why that is so is because some individual regret being sterilized. So that's why counseling and client assessment and screening is very important as a prerequisite before sterilization. And this counseling involves description of the different type of sterilization to the client, the risk and benefits that are associated with each procedure, as well as also discussing different alternatives to sterilization, which include long-acting reversible contraceptives. Also, very imperative before a couple is offered sterilization is preoperative screening, which include history taking and physical examination to be sure that sterilization is appropriate for these couples seeking contraception. What are the indications for sterilization? Sterilization, as I said earlier, is a form of permanent contraception. So it is appropriate for couples who do not want any more children and they want very highly effective contraception, and also they want a permanent contraception. They may also have been on some form of contraception before, but they had problem because of compliance, and then they don't have compliance because they need a procedure that will not need them coming back to the hospital. So a couple who have completed their family size and want permanent form of contraception, those are the ones that sterilization is appropriate for. I'll move on now to talk about methods of sterilization. Just as the topic of this module says, male and female surgical sterilization. So we have male form of sterilization, and then we have female form of sterilization. The female form of sterilization involves either occluding or disrupting the fallopian tube patency. That occlusion can be done either surgically, whereby a section of the fallopian tube is ligated, and it can also be done mechanically with the use of clips and rings. Electrical coagulation can also be used, as well as chemicals and microinserts. We would talk more on these ones as we proceed in the module. For males, we'll talk about vasectomy. For female sterilization, how does it work? It works by occluding the fallopian tube, and it prevents sperm ascending through the uterus to the point at which the ovaries, the ovums have ovulated. So it prevents sperm ascension to meet the ova for fertilization. Female sterilization can be categorized based on approaches and types. Approaches meaning how do we assess the fallopian tube? And there are different approaches to the fallopian tube. It could be abdominal, through the abdominal wall, through the vagina, or through the cervical. We'll still dilate more on this as we proceed. Through the abdominal access, it could be mini laparotomy, which is a small incision, about 1 to 5 centimeters in length, which is made on the anterior abdominal wall. And then the uterus and the fallopian tube is manipulated into this incision. It could also be via laparotomy, which is a larger incision, and the tube is also accessed through the incision. And it can be through a laparoscopy, whereby a tiny umbilical incision is made. A laparoscope is inserted through that incision to access the uterus and the fallopian tube. While the vaginal access is via a choridoscopy, which is a tiny incision through the vaginal fornix into the pouch of Douglas, through an instrument that is called a choridoscope. This access is very difficult, and it's also more prone to infection. So really, choridoscopy is obsolete. I'll move on now to talk about timing of sterilization. So apart from approach, we can also categorize the female sterilization by the timing. It could be immediately postpartum, meaning laparotomy may be more appropriate for that, because the uterus will still be at the level of the umbilicus, so it will be accessible through mini laparotomy. Female surgical sterilization can also be done during cesarean section, also that through laparotomy. It can be done following uncomplicated first trimester abortion, either through a mini laparotomy or laparoscopy, while it can also be categorized into call interval sterilization when it is done 6 weeks or more after delivery. And laparoscopy, hysteroscopy, or laparotomy may be appropriate approaches to interval sterilization. Royal College of Obstetricians and Gynecologists, they advise that a woman who requests sterilization soon after delivery should be told that the risk of regret and failure is higher when it is done immediately after delivery or following termination of pregnancy. Sterilization should be performed during follicular phase. The reason is because there could be an undetected luteal phase pregnancy at the time of the operation, and one does not want that to happen. And pregnancy test is a must, and that should be done to exclude pre-existing pregnancy. Types of female sterilization based on ligation or occlusion method. For ligation, the types include Parkland, Pomeroid, Madlena, coronal fimbrectomy, Uchida, and Arvin. I would discuss more on this as we proceed. Okay, so this is a picture that shows some of the types that I mentioned based on ligation. The first picture here, the first three pictures describe Pomeroy method, whereby a loop of the fallopian tube is brought up at the ensuring that you have a vascular window in the mesosalpinx. That loop is then tied with a suture, and then that segment is removed. That is Pomeroy method. While the one below this is Arvin. What is done is in Arvin is that a segment of the fallopian tube is excised, and then the proximal end of the fallopian tube is buried into a tunnel in the anterior wall of the uterus. That is to increase the efficacy of the tubal ligation. This is Madlena. What is done in Madlena is similar to what is done in Pomeroy, but the difference is that after pulling up a loop of the fallopian tube, the base is crushed with instrument before it is ligated and incised, while this last one is coronal fimbrectomy. The fimbria end of the fallopian tube is removed, and whatever is done on the right should also be done on the left side of the fallopian tube. Apart from ligation method, the tube can also be sterilized using occlusion method, and different occlusion methods are available. We can use the ring method or the clip method. The ring, example of the ring is the fallope ring, and the ring, fallope ring is a silicone rubber band. It is placed around the loop of the tube via a laparoscope. The tube tightens, it cuts off blood supply from the fallopian tube and fibrosis, and that fibrosis block the fallopian tube. Fallope ring is also applied to the isthmic portion of the tube and uses a special applicator which consists of a grasping prong. This is a picture showing fallope ring, and that's the applicator which will be inserted through a laparoscope, and that's the fallope ring applied to a loop of the fallopian tube. Tube occlusion can also be achieved with the use of clip. Example of clip include the Fisher's clip and the Orca-Clemens clip. Both of them also create pressure on the fallopian tube, causing occlusion of the blood supply and fibrosis. And that fibrosis occludes the tube. Fisher's clip is made of titanium with a silicone rubber lining and is applied also laparoscopically at the isthmic end of the fallopian tube. The silicone rubber is capable of expanding after application, and it produces a continuous pressure even when the tube becomes ischemic. That pressure will still continue. All right. So Orca-Clemens clip is different from Filshire because it has a spring. It is a spring-loaded clip, and that is also an improvement to ensure the outcome is better. This is a picture showing Filshire's clip. That's the applicator, also to be introduced laparoscopically, and that's a clip that goes around the fallopian tube. Also, tubal occlusion can be achieved through electrocoagulation with the use of diatemy. A portion of the tube is burnt with electric current, and that forms scar tissue which blocks the fallopian tube. It's associated with an increased risk of intraoperative bowel injury, ectopic pregnancy, and is more difficult to reverse. The reason is because it involves the use of diatemy, which burns tissue. So it's possible that as an intra-op complication, there could be bowel or bladder injury while that is going on. Royal College of Obstetrics and Gynecology again recommends that diatemy should not be used as first choice in patients, but may be used as an alternative if mechanical occlusion with either clip or ring fails. Okay, I will go now to talk about transcervical, which is hysteroscopic sterilization. Hysteroscopic sterilization is one of the approaches to tubal sterilization. What cervical or hysteroscopic sterilization does is that it avoids the risk of the associated with laparoscopic procedure, like the thermal injury that I mentioned earlier. It's not found. It may not be. It's not found in transcervical sterilization. It does not require an incision, and it doesn't require general anesthesia. Local anesthesia with sedation may be appropriate. It may be enough for transcervical hysteroscopic sterilization. How do we then? What do we use to occlude the tube? That chemicals can be used, like phenols, quinacridine sulfate, or methyl cyanoacrylate. Mechanical occlusive devices and diatemy can also be used. I'll still talk more on mechanical occlusive devices later in the course of the lecture. Electrosurgical methods have been abandoned because they were associated with high failure rates and adverse effects such as perforation and visceral damage. The mechanical occlusive device that I mentioned, one of the examples is a Shaw system. The other example is a Diana system. What is done in a Shaw system is it consists of a fallopian implant. Then that implant will be inserted through hysteroscope into the fallopian tubes, and these inserts would generate inflammatory reactions, fibrosis, and then tubal blockage. That implant, which is a Shaw, is a spring-like device with 40 millimeters in length and 0.8 millimeters in diameter. The insert comes loaded in a single-use delivery system. So it's loaded on a device through which it will be delivered into the fallopian tube. And it consists of an inner coil of stainless steel and the outer coil of nickel titanium. So if a patient reacts to nickel or titanium, a Shaw will be contraindicated. The implant is placed into the fallopian tube using a standard hysteroscope. The procedure can be done under local anesthesia, like I said earlier, with or without intravenous sedation. Over a period of 3 months, the insert would induce fibrosis and eventually cause tubal occlusion. Alternative contraception has to be used by the patient before tubal occlusion is confirmed 3 months later. And that tubal occlusion can either be confirmed with ultrasound or hysterosalpingography. So this is a picture showing a shore. That's the fallopian tube, and that's the a shore device. That spring unwinds itself immediately after introduction into the fallopian tube so that it can get anchored properly. Okay. So the next one, which is also an occlusive method via hysteroscope, is the Adiana method. It combines thermal damage with inserts. So a controlled thermal damage to the proximal fallopian tube is done with radiofrequency energy. And then a soft silicone pellet, usually about the grain of size of a rice, is implanted at the site of that at the site where the thermal energy is applied, and that will cause reaction, fibrosis, and then tubal blockage. Also for Adiana, one would have to confirm whether the tubes are blocked after 3 months, and so the client will also be advised to use alternative contraception before that is done. Failure rate is about 1.1%. Adiana actually has been removed from use for quite some time because of the complications and failure that may be associated with it. Complications of female sterilization. The complication can either be during the operation or post-operation, which can be immediate or long-term post-operation. Intra-op, there could be injury to surrounding structures depending on the approach. Like I mentioned earlier, during laparoscopy, there could be thermal injury to the bowel or the bladder. There could be adverse reaction to anesthesia, especially when general anesthesia is used. There could be it could be associated with severe hemorrhage because the fallopian tube is well vascularized through the mesosalpinx. And also, if it is done immediately after delivery, immediately after miscarriage, the uterus is well vascularized at this point, so hemorrhage may be a problem. Mortality from sterilization is very low, but when it occurs following laparoscopic sterilization, is about 8 in about 100,000 operations, and the commonest cause of death is anesthetic in origin. Immediate post-op period, patient may complain of wound infection. There could be hemorrhage. Long term, there could be abdominal pain and dyspareunia, especially if it was electrocautery that was used. There could be patients can develop intra-abdominal adhesions, which may predispose them to ectopic pregnancy later in life. Also some clients can complain of psychological and psychosexual problems. Okay, so female surgical sterilization is very safe and is very important, and many patients, like I said earlier, use female surgical sterilization. Are there any other advantage apart from contraceptives that a patient may also enjoy after having tubal sterilization? Researches have shown that ovarian cancer, the risk is decreased in patients who have had bilateral tubal ligation for contraceptive purposes. Also, the same thing with pelvic inflammatory disease. The incidence is also reduced in them. However, it doesn't prevent sexually transmitted infections. So clients should be told that. So if they should be told that barrier method will also be needed for them to prevent sexually transmitted infections. But what is known is that when the patient has had bilateral tubal ligation, that prevents ascension of the infection into the pelvic peritoneum. It should also be known that female surgical sterilization does not increase the need for hysterectomy. Researchers have shown that. Failure rate, yes. Just as you must have known from this lecture series that there is no contraceptive device that doesn't have a failure rate. So even as effective as female surgical sterilization is, it still has its own failure rate. And overall, the failure rate in tubal sterilization is about 0.7% and differs from method to method. Pulmonary method has the lowest rate of 0.1 to 0.5%. The failure rate increases when it's done during hysterectomy or during cesarean section, like I mentioned earlier. And the reason is because the uterus is well vascularized and the fallopian tube caliber is wider at those times. Failure rate of laparoscopic sterilization depends on the method that is used. When bipolar electrocoagulation has higher failure rate than unipolar method, as is seen in the slide. Failure may be due to fistula formation or due to spontaneous reanastomosis. We can't talk about failure of female surgical sterilization without making mention of CREST study. CREST study is a collaborative review of sterilization which was done in the United States, and it was a multi-center study that looked at about 10,000 women who have had female surgical sterilization over a period of 10 years. And the conclusion from that study is that although tubal sterilization is highly effective, the rate of sterilization failure is substantially higher than previously reported. And over 5 years, the cumulative probability of failure of sterilization methods was about 13 per 1,000 procedure. As can be seen in the slide, is comparable to failure that is seen in copper IUCD, which is 14 per 1,000 procedure. Over 10 years period, the cumulative failure of sterilization procedure range between 7.5 and 36 per 1,000 procedure. And then CREST study also concluded that postpartum partial salpingectomy had the lowest 5 years and 10-year cumulative pregnancy rates of about 6.3 after 5 years and 7.5 after 10 years per 1,000 procedure. Spring clip had 5 years pregnancy rate of 31.7 per 1,000 and 10-year pregnancy rate of 36.5 per 1,000. Sterilization failure, according to CREST, again, occur more commonly in women who underwent the procedure at a younger age due to increased fertility in those women. And there is also a substantial risk that any post-sterilization pregnancy will be ectopic. CREST study found that about 1/3 of post-sterilization pregnancy were ectopic. The cumulative probability of expressing regret following tubal sterilization, according to CREST, was about 12.7%. And they also found out that the factors that are responsible for regret among women who have had surgical sterilization include young age at the time of sterilization, postpartum sterilization, divorce or remarriage, and then poverty. Male sterilization now. So I will now move on to male sterilization. Male sterilization is safer and cheaper than female sterilization and is more commonly performed under local anesthesia than female sterilization. So because there is no need for anesthesia, it doesn't require laparoscopy. That is why male sterilization is cheaper, and it can also be done as office procedure. Ability to check for efficacy is also a clear advantage when male sterilization is compared with female sterilization. How to check for the efficacy, we'll talk about it in the course of this module. Division or occlusion of the vas deferens is done in male sterilization, and that prevents passage of sperm through the vas deferens. Division alone is associated with high failure rates, according to research, and that's why it is encouraged that facial interposition should also be done alongside vas division or use of diatemy. The vas can be ligated or occluded with clips or diatemy, but clips appear to be associated with higher failure rates and are not recommended. Actually, no one seems to be more effective than the other, but the non-scalpel vasectomy is associated with reduced incidence of hemorrhage and infection, and therefore non-scalpel vasectomy is recommended by Royal College of Obstetrician and Gynecology recommendations. This slide shows different types of male sterilization. It could be surgical or non-surgical. The surgical method includes vasectomy, which could be conventional vasectomy with the use of scalpel, and then a non-conventional vasectomy. Also, electrical ablation is also a method of surgical male sterilization. While non-surgical male sterilization include percutaneous, intravasal injection of sclerosants. An example of those sclerosants include carboxylic acid. Vasectomy is a permanent form of sterilization, like I said earlier, which is done on male, where a segment of the vas on both sides is resected and removed. Advantages of male sterilization, which is vasectomy, include the technique is simple to perform and it doesn't require too much of training. It can be done on an outdoor procedure, and in some countries it's done in mass camp where males who want to be sterilized are gathered and then they are done at a go. The immediate and later complications are fewer in male sterilization, and failure rate is also minimal. It's about 0.15%. The overall expenditure is minimal in terms of equipment, hospital stay, and doctor training. Really, patients don't need to stay overnight for vasectomy, so it's actually very, very cheaper compared to female sterilization. The drawbacks: additional contraceptive protection is needed for about 2 to 3 months. So, following vasectomy, a man does not become sterilized immediately. So, there will be need for such a client to use additional contraceptive for about 2 to 3 months. And then impotency and frigidity have been reported by some men, and this mostly is psychological. Conventional vasectomy is almost exclusively performed under local anesthesia, whereby a midline incision is made or a 2 scrotal incisions are made, and through this incision the vas deferens is accessed and then occluded or ligated. Method of occlusion include ligation, excision, clips or clamps, cautery, or combination of any of this, and then facial interposition makes the efficacy to be better, like I said earlier in the course of this lecture. Non-scalpel is more commonly done, is an improvement over the scalpel method, whereby the vas deferens is identified through a scrotal puncture site. This approach is used more frequently worldwide due to fewer infections and also hematoma. So, hematoma and infection could be a complication of scalpel vasectomy, but with non-scalpel vasectomy, these are fewer. And then there is less pain, so there is less need of use for analgesia. And then early resumption of sexual activity is noticed with patients who have had non-scalpel vasectomy. So this is a picture that shows non-scalpel vasectomy. And local anesthesia is applied. Then the vas deferens is identified and aired with a ring clamp. And then the skin over the vas deferens is punctured. And then that vas deferens is brought out and excised. Postoperative instructions: patients will be told to apply ice to the incision site to reduce swelling and pain. They should rest from work for about 48 hours, keep the site of operation dry for about 2 days, and avoid strenuous work for about a week. Sexual intercourse can be resumed when the patient feels like, but should be told to use Barra method or any other backup method to avoid pregnancy for such a duration of time when he has had 2 consecutive negative sperm counts, all right, over a 4-week apart. Where sperm counts cannot be done, the client should use the backup method for about 12 weeks or after or for 20 ejaculations. So after 20 ejaculation, most times the vas deferens will be free of spermatozoa. Azoospermia results in 60 to 80% of women after 12 weeks or after 20 ejaculations. Okay. Recent researches actually have now shown that it could be longer for vas deferens to be clear of sperm. So it's more appropriate to check the sperm for spermatozoa and ensure that the patient has had 2 consecutive negative sperm analysis. Then the skin stitches will be removed on 7th postoperative day if non-available stitches were used. Clients should also be told to report in the hospital immediately if there's bleeding, if there's infection, if there's sperm granuloma, or there's chronic testicular pain. Complications of vasectomy could be intra-op, immediate post-op, or long-term. In intra-op, the patient could have scrotal bruising, hemorrhage, and immediate post-op, about 1 to 2% of them may have scrotal hematoma. They could also complain of wound infection, while in the long term, they can develop anti-sperm antibodies, sperm granuloma, epididymitis, or chronic testicular pain. Efficacy of vasectomy also was studied in the CREST report, and cumulative probability of pregnancy per 1,000 vasectomy was 7.5 during the first year, and this rose to about 11.5 after 5 years. It is difficult to establish that all the reported pregnancies following vasectomy were due to these patients. Okay, even at that, vasectomy is very effective. Some patients regret vasectomy, and according to CREST, factors responsible for regrets include marital instability, age younger than 31 years, financial instability, or when such a client or the couple, they have none, or they are very young. The ages of their children are very young at the time of the sterilization. So the clients may regret, the chance of them regretting vasectomy is higher with these factors. Impact of vasectomy on long-term health. Does vasectomy increase the risk of a man to having any other disease in the long term? And there has been concern that vasectomy may increase the risk of atherosclerosis, testicular cancer, or autoimmune disease, but large-scale studies have failed to substantiate this concern. Also, it has also been thought that maybe risk of prostate cancer is also increased in patients who have had vasectomy. This has also been disproved by study. The clients should also be told that vasectomy does not confer any protection against sexually transmitted infections or HIV. How do we then improve safety of vasectomy? By use of local anesthesia, avoid infection, ensure that the surgical site is inspected for bleeding, then we counsel patient to recognize complications. Then I'll go on to talk about reversal of sterilization. Reversal of female sterilization involves laparotomy with limited success rates, about 70% success rates if microsurgical technique is used, and it carries a significant risk of ectopic pregnancy. Up to 5% of patients who required reversal of sterilization may have ectopic pregnancy. Reversal is more likely to be successful after laparoscopic clip compared to laparotomy procedures. Reversal of vasectomy is technically feasible, and patency rates can be achieved in about 90% of patients after vasectomy, but pregnancy rate in them is lower. About 60% of them achieve pregnancy, and this may be as a result of anti-sperm antibodies, which is a complication of vasectomy. So, reversal of either male or female surgical sterilization is a complex and expensive surgery. And then those who are eligible for reversal, they are limited because of age and fertility status. And then the success rate is also limited. Live births occur in about half of patients who required reversal. So reversal is limited in access, limited in eligibility, and limited in success. All these should be discussed with the clients before choosing surgical sterilization. There have been myths about male surgical sterilization. That does it cause? Is it a castration? Does it reduce sexual desire? These have been dispelled by researchers. A vasectomy is not a castration. The man can still achieve erection. It doesn't reduce sexual desire. It doesn't reduce the quality of the ejaculate. Only that there won't be spermatozoa in the ejaculate, and no loss of male physical traits or strength. And it doesn't affect urination. So it's very important to counsel the patient in any form of contraception that they may want to choose. And more so, for surgical sterilization, it's very important to counsel them. An informed choice has to be made. The patient and the couple would have to be provided with adequate information about contraceptive options. As many as 10% of couples may regret being sterilized, and about 1% of them may request reversal. So that's why couples would have to be counseled. They should be told that when they are sterilized at young age, immediately after delivery or an abortion, the regret is higher. And then a change of partner is a common reason for requesting reversal. So what are the items to be considered during the couple counseling? The age is very important. Those who are less than 30 years are more likely to regret the decision. Family size and possibility of wanting more children is also very important. In fact, the CREST study shows that couples who have 2 or lesser number of children, they have higher risk of regrets following sterilization. Previous or current contraception and any problem experienced will have to be discussed, and which partner to be sterilized will have to be discussed. Decision for family planning is a couple decision. So if a couple presents, they are counseled and then they decide whether they are going to have vasectomy or the woman is going to have tubal sterilization. Stability of the relationship is also very important, and possibility of breakdown of that family is also important to be discussed during counseling session, because marital disharmony is one of the factors that may cause regrets and that may make the couple or the partner, one of the partners, to ask for reversal of surgical sterilization. Also, the procedure needs to be discussed with them, the failure rate, the risk and side effects, reversibility also needs to be discussed with them, and then practical arrangement. For example, the need to use backup contraception before it is established that either the tubes are already blocked or the vas deferens is already blocked. Okay. So in summary, surgical sterilization is safe, effective, and convenient. Counseling is essential to ensure voluntary choice, and quality of health facility with referral network and well-trained staffs are needed to make voluntary sterilization more widely available. At the end of this module, I have some multiple choice questions, which are 5 of them with the answers, and then single best answer, also 5 of them with the answers. And then I have an essay. I will talk a bit for like about 1 minute about this essay, what is expected. A 40-year-old para 4 came in for a day surgery, and she's planned for laparoscopic sterilization. The question is, what should be explained about sterilization, and what are the risks of sterilization operation? What should one ask in her history before operation? And then on questioning, she mentioned unprotected intercourse on several occasions since her last menstrual period. Her period are generally regular every 28 days, and her last period was 3 weeks before presentation. Justified management of this case. So what should be explained about sterilization? She is coming in for a day surgery for laparoscopic sterilization. So key points there: she's para 4, she has had unprotected intercourse, and she's coming in for sterilization operation, and she's medically fit. If she's not medically fit, she wouldn't be booked for a day case. So we describe the laparoscopy as regarding sterilization. What are the risks? What are the procedures? Risk involved, risk of anesthesia, risk of the sterilization, and risk of the technique. Okay, and then the alternative to sterilization we'll have to discuss with this client. And then secondly, these are the history that should be taken from the patient. Okay, and then the third question is she has had intercourse in the last 3 weeks before presentation. So the risk of luteal phase pregnancy is there, and one does not want this to happen. So the role of pregnancy test needs to be discussed in this essay. And then if the woman has had intercourse in the 5 days preceding the procedure, emergency contraception should be offered. If one cannot adequately say that she's pregnant or not, then the procedure should be postponed, and then she is encouraged to prevent unprotected intercourse before the next date. Risk of ectopic pregnancy with the operation should also be considered. So in the last about 30 minutes or thereabout, in this module, I've discussed male and female surgical sterilization. If there's any question, it can be dropped in the comment section. Thank you.